The porphyrias are a group of metabolic disorders caused by altered enzyme activity that are essential for making heme for hemoglobin. This results in half-baked intermediates that accumulate in various organs. Where these precursors build up correlates to what clinical manifestations will be seen. In this video, we'll focus on the two most common types, Porphyria cutanea tarda and acute intermittent porphyria. At the end, I'll go through some important points by giving you a quick mnemonic to help you remember the most important stuff. Let's start off with some pathophysiology. Red blood cells are filled with hemoglobin, which help carry oxygen around your body. Hemoglobin is comprised of 4 subunits, each one having one polypeptide chain and one heme group. Now, heme has 2 important components, an iron atom and a ringed molecule, which is a specific type of porphyrin, protoporphyrin 9. To make this special porphyrin, we need to go through a complex biosynthetic pathway that no one's ever going to remember. Each of these steps requires a specific enzyme, and if you have a deficiency of any of these, a toxic precursor builds up, and hey presto, you've got a type of porphyria disorder. For example, Porphyria cutanea tarda is caused by a defective uroporphyrinogen decarboxylase enzyme. This results in a backlog of unprocessed uroporphyrinogen, which accumulates and causes damage. The clinical features of porphyrias fall into 2 groups, photosensitivities and acute neurovisceral syndromes. This is because some porphyrin precursors causes damage when exposed to light, while others are damaging neurotoxins themselves. Often there's a mix between the two. Let's go through the 2 most common types of porphyria. Porphyria cutanea tarda, or PCT, is the most common type of porphyria. It is a photosensitive type, and as mentioned before, it's caused by a defective uroporphyrinogen decarboxylase enzyme. 25% of the time, this is due to a genetic familial cause. However, most PCT is acquired as the liver can't make the enzyme, secondary to damage from things like iron overload, excessive alcohol consumption, hepatitis C infection, or excessive estrogen-containing preparations. It causes clinical features including blisters and crusted skin lesions on sun-exposed areas in response to minor trauma, skin fragility, excessive hair growth, itching, and dark reddish urine. This occurs because the accumulated precursor gets excreted in the urine and has a dark red color. PCT is investigated by measuring the plasma and urine porphyrin concentration. You should also think about getting genetic screening for inherited causes and investigating underlying acquired causes like hepatitis or hemochromatosis. Management often includes repeated phlebotomy and low-dose hydroxychloroquine, along with avoiding exacerbating factors like alcohol. On the other hand, acute intermittent porphyria, or AIP, is an acute neurovisceral syndrome. This means it causes issues due to effects on the nervous system, triggering central, peripheral, and autonomic neuropathies. AIP is caused by a rare autosomal dominant inherited disorder characterized by a partial deficiency of porphobilinogen deaminase. Most individuals remain asymptomatic, but symptoms can be triggered by the use of certain drugs, steroid hormones, and restricting caloric intake. The most important presenting feature is abdominal pain. This is the most common symptom and is usually severe, steady, and diffuse pain. The pain is neuropathic and is not accompanied by inflammation, so its response is poor to analgesia. Nausea, vomiting, and constipation are also common and are probably due to autonomic dysfunction. Similarly, tachycardia and hypertension are frequently noted signs. Seizures may also occur during acute attacks. Moreover, psychiatric symptoms like psychosis are also important features. As it's so rare and presents with such non-specific symptoms, it can be really hard to pick up. It's also investigated via a serum and urine porphyrin level and genetic screening. The aim of management is to hasten recovery from acute attacks and prevent future attacks. Acutely, Giving IV hemin decreases the production of the precursor that builds up in AIP. Otherwise, it's mostly supportive. To prevent future attacks, most patients just need to avoid triggers. However, givosirin is a new treatment available for severe cases. It's a long-acting RNA interfering therapeutic that decreases the breakdown of the deficient enzyme. Here are some really good mnemonics to help you remember the important things about the two most common porphyrias. The main manifestations of Porphyria Cutanea tarda include PCT features, like photosensitivity, cutaneous blisters, and tea-colored urine. To remember parts of the management of PCT, you should just remember that the patient needs to stop drinking mead, bleed, and then needs to be hydroxychloroquined. This is a reminder that alcohol cessation is important because drinking is a trigger, and venipuncture and hydroxychloroquine can help reduce porphyrin levels. On the other hand, the classic triad of acute intermittent porphyria, or AIP, is conveniently also a mnemonic itself. The main symptoms and signs include autonomic dysfunction, insane psychotic features, and pain, specifically in the abdomen. Before we finish, please take the time to subscribe and turn on your notifications. It helps grow the channel and keeps you connected. Thank you for watching Townsend Teachings. Don't forget to like, comment, subscribe.